Ladies and gentlemen, I think it's the right time to start. We have a very crowded session. You see, we have 4 speakers, 4 panelists, and we have to finish in 45-50 minutes. So what we have decided that the panelists makes a very short presentation, and then we have together the panel discussion. So I will request Professor Hasnain from Dubai to say about Ramadan and diabetes.
Okay, assalamu alaikum. Good evening, everyone, or afternoon rather, not evening yet, not very far. So my part for that important panel discussion was in relation to Ramadan fasting. Of course, for Ramadan fasting is, as you can see from this graph, is practiced by the vast majority of people from a Muslim background and diabetes, but with huge variations from country to country. Some countries feel that, for example, a person on insulin, whether they're type 1 or type 2, is no fast, not at all. But in many other countries, the majority are fasting, as you can see, as data from Saudi Arabia, Bangladesh, KSA's Kingdom of Saudi Arabia, whether it's type 1 or type 2. But because of this diversity, now a person with diabetes doesn't come with just diabetes. They different age, different risk factors, different comorbidities, different duration of diabetes, different types of therapy. And because of all that, we need to have an objective method of risk assessment. So the IDF 4 years ago, along with Diabetes and Ramadan, developed the risk calculator. Because if I were to put a case scenario today, and in this room, we could end up with 5-10 different opinions. That's not right. What is right, that we have something objective that we can assess. And there's no better assessment than the risk calculator, which already has 10 different studies that have looked into the validation of the risk calculator. Because as you can see, we're talking about 14 different elements of calculation with 54 different subcategories. So it comprehensively goes through all of this. You can download this through the app or online or indeed printed. Many of us have it already embedded in the electronic medical records. But to adopt and accommodate the tradition and the cultures of every person, of course, we need to provide education. And education needs to be done in a simple way, in the language of the person with diabetes, and to look into the different aspects of Ramadan, not just the fasting, but also the eating and the drinking and the feasting. And education actually works. As you can see from the chart, the 10% versus the 14.8. 10% is the rates of hypo in those who received education. The 15% nearly, or the 14.8, is the rates of hypos in those who did not receive education. So education for fasting, whether it's Ramadan fasting or any type of fasting, is key. And I'm delighted that many of the people in the room are from this sort of passion for education. But also monitoring is very important. A key element in the education is the monitoring. The timing of the monitoring, the frequency of the monitoring is very important. Can I monitor, or it invalidates my fasting? In some countries, they think that doing the blood glucose monitoring is a taboo during Ramadan. Of course, the regulation in Ramadan is what is required and deemed as essential is allowed, even is naturally forbidden. So knowing my blood glucose level, now it's 4 p.m. Let's assume it's Ramadan and I'm fasting and on insulin. I must know whether it's safe for me to stand up and give this lecture, or I'm approaching of getting hypoglycemia, rather than wait until it happens. So monitoring is really key for this. And then finally is the treatment choices. Some treatment are Ramadan friendly or fasting friendly. Some treatment are less friendly, and they need adjustment in choice, in dose, in timing, and of course, in relation to the other aspects of the person's life. So, ladies and gentlemen, Mr. Chairman, in summary for my brief key points, to allow enough time for the discussion, that we have plenty of studies that look into the risk factors for people who wish to fast. Of course, the type of diabetes, the type of therapy, the lifestyle of the person, the age, the duration, the comorbidities are all important factors. Regardless of what we say, the vast majority of people from a Muslim background wish to fast, and in many cases against medical advice. So our job is to try to, in a friendly, non-confrontational way, to do the risk assessment and work with them to modify what is modifiable. So if today my risk is high, maybe after a bit of intervention, I would be able to lower my risk category. So that's why we need the systematic approach. Of course, the choice of therapy and the education and the frequency of monitoring and the timing of therapy would also be quite important. I'll stop here to allow enough time for the panel discussion on the topic later. Thank you.
I will now call upon Ellen Cho from Hong Kong to say complementary and alternate medicine, please.
Thank you very much for the kind introduction, and it's my pleasure to be invited to speak on the topic of complementary and alternative medicines. And my disclosures. So, it's just useful to revisit the definition of CAM. So, complementary refers to therapies that are used in conjunction with conventional medicines, whereas alternative refers to therapies which people are using instead of conventional medicines. So, I think many of us, especially in Asia, practice in integrated settings where people are probably using both, conventional and, complementary medicines or CAMs together. And I think the question is how we can sort of achieve, truly integrated medicine using, an evidence-based approach. So here, this is just a summary of, the current landscape of what we call, refer to CAMs. And I think we could probably divide these into three large categories. So first of all is what we call, herbal remedies, mostly biological products. Many of them, I'm sure, you are probably familiar with, and some are regarded as functional foods. So here I'm able to just briefly highlight some of the ones which are most popular. So for example, cinnamon and fenugreek, it's, spices that are, used in a lot of cooking, curcumin, and for example, the bitter gourd in the Chinese culture is all believed to have, medicinal properties. And there are a lot of also traditional Chinese medicines which people use for diabetes. The second category belongs to dietary supplements. So I think in the recent maybe 5 to 10 years, we've seen a huge explosion of this industry, and we see many shops which are dedicated to selling different types of dietary supplements. Amongst the numerous ones, I think the two of the most commonly used and believed to help with diabetes are probably magnesium and chromium, and I will talk about this a little bit later. So the third category belongs to what we call mind-body therapies or holistic approaches. So in this, we would talk about therapies such as yoga, Tai Chi, and meditation. So because, I've been allowed a few minutes, so here I've just selected a few examples of, each of these categories to illustrate, what the current evidence is and how people might apply it. So the first I've chosen is berberine. So berberine, it comes from this plant, the Rhizoma coptidis. Berberine has been used in traditional Chinese medicines for many years, used for diarrhea, and also commonly used in part of many herbal remedies for diabetes. And actually, very interesting because berberine has properties very similar to metformin. It also activates the AMP kinase. On the next panel here, this is actually a rodent study that was done by our group, Professor Gina Chan and her team. So this was actually an animal study where we gave these Sucovava rats a herbrin-containing herb. So on the A and C panel here, these rats received the berberine-containing herbs for about 2 weeks, and then after they stopped the medication, there was a sustained improvement in the hepatic steatosis, which lasted for a long time. In terms of sort of solid, human evidence, I think this is one of the sort of more often cited clinical trials. So this was a trial that was conducted in 36 patients with newly diagnosed type 2 diabetes. They were given berberine or metformin at 0.5 grams 3 times a day for about 3 months. And you could see here, comparing berberine monotherapy or metformin monotherapy, there was a similar reduction in both fasting and postprandial glucose. So the postprandial glucose also reduced by 4 millimoles, which is almost similar to the metformin arm. So the next, I was going to talk about supplements. So this was a study that we collaborated with the School of Pharmacy in our institution, and this was looking at the pattern of supplement use. This is in the US from the NHAIS database, and out of about 8,000 adults with diabetes, about 54%, half, were self-reported dietary supplement use. So I'm not sure what the figures are in other parts of the world, but I think it's probably also very high. And it's interesting the types of supplements that are most used. So amongst them, probably the vitamin E, folic acid are most common in use. But also if you look at the minerals, you can see here magnesium and manganese are also extremely popular. Now, I'm only in the interest of time, I could probably just illustrate using magnesium as an example. So we know that magnesium is actually quite an essential mineral in the body. It's a cofactor for enzymatic activities regulating insulin. So we can, get magnesium from many sources of diet, such as whole grains, beans, and nuts. So, there's now a lot of evidence out there, basically more from cohorts of observational studies. And one example is this meta-analysis I've shown here. If we look at, the association between magnesium and the risk of incident diabetes. So for every 15% increase in the magnesium by 100 milligrams per day, there was about a 15% decrease in the risk of incident diabetes. But if you're looking at, supplementation trials, so actually the evidence there is probably a little bit weaker, and we probably do need proper randomized trial to see whether actually magnesium supplementation can reduce the risk of diabetes. Now, I think we should also talk about yoga. So I believe it's practiced in India, and I'm very encouraged by this particular picture, which actually showed a large group of men who are practicing yoga in a public park. There are lots of beliefs about how yoga might be useful. So, for example, it's been shown to reduce sympathetic activation and activate the vagal system. And via this neurohormonal link, you might reduce systemic inflammation, and also not to forget, the importance, mental well-being. So it can help promote, feeling mental health, and also help a little bit with weight loss because it's a low, moderate intensity exercise. So in a systematic review of about 44 RCTs from about 3,000 people, it showed that actually yoga was able to significantly reduce the blood glucose levels. There are sort of growing number of RCTs out there who also are showing maybe there are sort of sustained benefits for doing yoga therapy. So I just wanted to finally highlight some of the challenges in integrative care. So these are just some of our observations, probably from our local setting. So I think one of the first challenges is, we need healthcare professionals who have knowledge of both conventional and alternative medicines. And that sometimes is actually quite difficult to have this broad grasp of knowledge. And for many, diseases, there might be very different beliefs of disease models. So for example, in traditional Chinese medicine, there's this belief about the yin and the yang and the heat and the cold. And these concepts, vary very quite differently to, Western medicine approaches. And one of the challenges we find is you need a common system to prescribe and monitor. So we do have some integrated medical clinics, but we need to be able to see what the Chinese practitioners are also prescribing, and they also need to be able to see what medicines they are being received, because the potential is there for herb-drug interactions, and some of these are potentially significant. And also, in this context, there might be also maybe supplement drug interactions. One of the other concerns is herb-related liver injury, which can occur with certain herbs if they are not used correctly. The other, some of the issues which I believe apply quite broadly is the regulation of CAMs. So in Hong Kong now, they are for some proprietary TCMs, there's quite a high level of control, so they all need to have GMP manufacturing. There is a specific authority where they need to register and have regular inspections. However, the potential for adulteration remains, and even in our local experience, we've had quite a few high-profile cases where some traditional herbal medicines were adulterated with things like glibenclamide, tolbutamide, and also sometimes thyroxine supplements. So this is something we need to think about, how we can safeguard the quality. And finally, I believe that what we need is also a common evidence framework. And by this mean, we're also using the RCT as the highest level of evidence to evaluate these CAMs. And in the picture here, this is just one example of a integrative medicine, Western and Chinese medicine clinic in our own institution. And we're working closely with our TCM practitioners to maybe try to integrate using both Chinese and Western medicines to try to prevent diabetes. So I'll end my presentation there, and hope we'll have a discussion later on with the panel. Thank you.
It's difficult task to summarize in such a short space of time. Now we may request Dr. Sunny Yong from Singapore. Please.
Thank you very much. And first of all, I'd like to thank you, the organizer, for having me in this section. And so we're going to look at prebiotic, probiotic, and the microbiota. And I think I will split it into two parts. First, in looking at microbiome and metabolic condition, I know yesterday in Max Newjob's talk, he mentioned about the microbiome, but for those who haven't been there, so we will have one slide actually to look at the microbiome in different metabolic conditions, including diabetes. And I think the second is, of course, what we are, as clinicians, we are most interested in to modulate the microbiome to achieve a better health or control in diabetes. And I will talk on these three aspects. So I think when we look at metabolic disease, obviously there are a lot of them, including diabetes, but apart from them, of course, fatty liver, cardiovascular diseases, obesity as well. And I think we survive to say that we can see that microbiome is involved in almost all of them. And this is a summary that I pick up from a review paper, but it is a very busy slide, and you'll recognize that there are a lot of bacteria names that may not be so familiar. But I think one message that you can get is that across these diseases, when we look at the gut microbiome, so they are all different. So different bacteria, different composition. Another thing that you also see is that although there are a lot of names, there are a few overlaps. There are a few key ones. One is called Akkermansia that come up from the top one here, and I think it's among the few that we know that there are gut commensals that are changed in people with metabolic conditions, and they are very important. Apart from that, of course, related to digestive diseases and other conditions, and we know that microbiome are different and also play an important role in these conditions. So when we look at microbiome modulation, there are not a lot of ways, but I think on the left you can see there are different approaches. There are genetic engineering phage as well. They are not really so ready right now. So I will talk on three that are a bit more ready. Firstly, about food or nutrition, including prebiotic, and secondly, on probiotic that we have been using, and I think lastly, on fecal microbiota transplant. We know that for among many factors, food or nutrition is very important for metabolic diseases, including diabetes, but the other aspect is that they are also very important for the microbiome microbiome. So I think this is actually one of the most important things that actually dictates and governs your microbiome. And across here, you can see that different diet, high-fat diet, high-fiber diet, Mediterranean diet, they all affect the microbiome to a very large extent. And we are in Singapore, we also have a population cohort, and we are looking at the effect of how people of three major ethnic groups they eat, and also how it relates to their microbiome and metabolic health. And I think there was one study that we were involved in, but looking at overweight and obese Chinese individual, looking at symbiotic. And I think in this, not a very large study, 55, but in a way, RCT randomized into dietary intervention, symbiotic, and also combined. But what you can see here is that among the three groups, the combined group that has the prebiotic and the probiotic, they did achieve a better metabolic profile with weight loss and also better glycemic control, and also that is related to some microbiome with some taxa that are associated with a favorable response. The other bit is the probiotic. We know that this is important as well. We have been using probiotic for many years, but there is right now a new concept. And you can see that they call it next generation probiotic or live biotherapeutics. The reason is because for many years, we know that probiotic about bifidobacterium and lactobacillus, but for a long time, we were not able to culture a lot of these microbes. So with advances in technology, we're now able to culture them, we're now able to sequence them and find out what they are. We find a lot of these gut commensals that are important, especially for our metabolic health. We mentioned one called Akkermansia menisciphilia. We know that this is underrepresented in people with diabetes and obesity, and we know that they are very important for our metabolic health. And also there are few that include some work that we did with Roseveria. So we recently, among with colleagues from Taiwan, we published a paper looking at development of these live biotherapeutics that uses bacteria as potential therapeutic, and they could be playing a very important role with metabolic diseases. This is one paper that I think I will highlight, one bacteria called Akkermansia. We mentioned about this bacteria because this is what we call a keystone bacteria. So they are very important when we look at the intestinal barrier and the mucin level over there. They're important to maintain the healthy barrier over there. And I think the belief is that this is also playing a very important role in absorption of energy and also endotoxemia with translocation of bacteria and the antigen. So in the left, showing one paper in Nature Medicine a few years ago, but looking at Akkermansia, but in a way, it's a small study, but they show conclusively that they were able to significantly reduce the weight and also improve the cholesterol and also improve the insulin sensitivity. On the right is a paper related also with Akkermansia, but not in overweight, but in diabetes subjects. Also quite a positive studies showing improvement in the glycemic control. So far, lastly, fecal microbiota transplant. Surely you might have heard of it, and it got very popular on the news as well. So this was a landmark paper that was done in Holland. They looked at duodenal infusion of healthy fecal biota, and they transplanted into donor recipient with recurrent C. diff infection. And I think in that paper, it was a landmark paper because it was drastic improvement. So that got the whole world attention on fecal microbiota transplant. But mind you, this is recurrent C. diff, and we know that it could be different for different conditions. So there are a few studies looking at metabolic syndrome as well. So for example, one of the first study actually from Holland as well in gastroenterology 2012, showing improvement of insulin sensitivity and also microbial diversity when we do FMT from lean to people with metabolic syndrome. And also one work that I was involved in, looking at Chinese individuals who are obese and diabetic. And I think in a way, the weight loss is not very clear cut. So in a way, the clinical endpoint, I think, is not significant. But in a way, we did observe changes in the biomarker, also with microbiome that correlate with their response as well. So I think I will just end here, and I welcome any question in the discussion as well. Thank you.
Thank you. Now may I call on Eram Kapoor to present a view of the people with diabetes.
Thank you, and hello everyone. You were listening the experts thing. Now I'm going to give the views of people with diabetes. And how can I change this? Okay, thank you. So, why that topic matters for us? This is the main question, because this is not something like which is a very common topic. So why this topic, the traditions meet sciences, is important for us as a person with diabetes. So this is important because the people with diabetes are increasing day by day, and recently, just 2 days ago, the Diabetes Atlas has launched, and according to that, 89 million adults are there worldwide. And the other thing is that it is important because tradition and modern treatments coexist for us. And there are many people who has diverse concept, diverse perspective about diabetes care. So that's why this case is very important. We have some traditional approaches of diabetes, such as Ayurveda. I will go quickly for this. Herbal remedies like bitter ground, fenugreek seeds, and the neem. You can relate that with your own culture. And this is, these kind of things are deep rooted in many cultures, so we can't deny them. And the Chinese medicine, the famous Sangjing and Barbarian Ring, and they are quite famous remedies and traditional approach to treat diabetes is still in many cultures. And another tradition is dietary and lifestyle practices. For example, the low glycemic whole food diet or whole grain diets, the mindful eating, and I would say it is in fashion, the intermittent fasting. And I must say that is benefiting many people with diabetes. And walking after meals, yoga, and hygiene exercises, etc. Another thing which I think now you have seen the picture of traditional things. The modern advances which we have right now, and we are availing that is new medication and insulin therapies like long and rapid acting insulins, GLP-1s, and technology and digital health is also accessed by many people with diabetes, such as CGMs, insulin pumps, different apps, and precision medicines. Genetic studies, genetic research for personalized or individualized treatment is very much nowadays accepted by the people with diabetes, and also gut microbiome studies is also taking in consideration. So actually, what is the perspectives of people with diabetes? I will categorize it in 3 categories. The first category is traditional approach supporters. Those people who prefer natural remedies and lifestyle over medications, but they are worried about the side effects. They doesn't know, because there's no medication no evidence there for this. So many people are worried about the side effects. The other category is science and technology advocates, who are believing on technologies and real-time data and precise glucose control. And also, but this is again, the problem is the cost and the availability for this. For example, if I want to use the latest insulin pump, then maybe that is out of my pocket and out of my reach. And the third category is balanced approach seeker. I belong to that category, which sees this as the combination of traditional and modern treatment for holistic care. Holistic care, how can we approach to holistic care? We need to bridge the gaps. We need to bridge the gap to achieve the holistic care. And how can we do this? We should integrate lifestyle and sciences. This is not working. Using different apps using CGMs, using different real-time apps. You can say that the cloud-based apps for the traditional approaches or traditional practices or remedies which we are using, and combining the traditional remedies with physician guidelines. We must take in the loop our physician that we are eating the cinnamon or the bitter ground. And that all should be patient-centered, because we need to understand that all the run is about the patient, and personalized treatment plans based on individual needs, their preferences, and according to their wills. And the last, that addressing affordability and accessibility issues as well. Excuse me, can you please? This is not working. So we need to bridge this gap by integrating all those measures, and we need to balance it. This is not about only the tradition, because I am not against the traditional medicines and the treatments, but we need to monitor our glycemia with the innovation. This is, in conclusion, in this era, diabetes care is evolving, and both traditional and modern methods have their own values. We can't deny them. And people with diabetes should shape them by their own voice, by their own thoughts and will. And what should be the call of action for us? That we educate the integrative patient-centered diabetes care, and more research should be done on traditional remedies and modern sciences. And I will sum up in one line, then we should combine the old wisdom and innovation, and maybe that is the best path forward for diabetes self-care management for all of us. Thank you.
I think you will all appreciate that the presenters achieved impossible task, because such a short time they made a summary of the presentation. For me, is just to thank them all, except that I want to add 2 or 3 comments. Number one, Ramadan and fasting. You see, I'm a Muslim by birth and by faith. You see, the God has decreed that you should not fast if your health does not permit. So I think we should tell the patient that. And also, fasting, Ramadan gives an opportunity, because they can fast better, more safely, if they bring diabetes under control and they get self-educated. This is the comment I want to make. Secondly, about traditional medicine, we know that now diabetes, most of them can be brought under control by modern medicine and treatment. The traditional plant-based therapies is, if it is safe, can be tried, of course. But generally, at least in our part of the world, people think the plants are safe. But all plants are not safe. If you recollect, the Socrates diet was killed by a plant, hemlock. So that's the plant. So plant can be quite toxic. And secondly, we should tell the patient, you may try the plant if it is safe, but please check whether your blood sugar is under control. Second thing. Now the floor is open for panel discussion. So I may interrupt for substantial one thing. You see, I found out by consulting religious experts that Ramadan, the fasting can continue. You can check your blood glucose while fasting. It does not make any difference to your fasting. You can also take insulin. while fasting. It does not matter, because in let's say in Bangladesh we have a very large diabetic outpatient, you see, and also in East London, my colleague Graham Edman, we found that people would come to the center just before Ramadan. Is such a large number, it's very difficult to, but they would not come during Ramadan.
Sure.
So we consulted religious experts, got it checked by Al-Azhar, whose fatwa is usually taken as semi-official, and also by the Grand Mufti of Kaaba, and found that during Ramadan, you can fast, but at the same time you check your blood glucose, and if needed, you can take blood glucose, you can take insulin. I thought I read that, pretty sure.
So a couple of comments. First, the religion allows the person who is ill not to fast. The big question is, who is ill? Many people with diabetes don't consider themselves ill, or don't know how the impact of the fasting could be on them. And hence, it's the importance of the evidence and the science and the healthcare professionals' involvement to guide the person to say safe, unsafe, or not sure. As for your comment about the feasting after eating, it's very true. It's meant to be the month of fasting, but if I ask 1 million families across the globe who are in Ramadan, how much money they spend during the month of Ramadan on food and drinks versus the other months, they would say they spend more money, although it's meant to be the month of fasting. Because it's the celebratory, it's not the religion, it's the celebration during the month where people would like to invite each other and have more food. Or maybe when you're fasting, you're focusing too much on what will I eat, and then you end up with bigger meals. Obviously, this can affect a person with diabetes who maybe before Ramadan already, their control was not great. So all of this need to be taken into consideration, and that's why in the comprehensive risk assessment, it certainly would look into hyperglycemia as well, and that's why the monitoring is essential, not just during the fasting hours, but also during the eating hours, for behavior change, for adjustment of therapy, for the type of therapy, and so on.
So my question from Ms. Chow is that complementary and alternative medicine, there is traditional aspect of research is that you take the plant and you extract all the active ingredients and test them one by one on animals, and then test on humans, and this is the traditional way. But people are using some things over generations and over many centuries. So they may be considered safe, and if we go that classical research pathway, then it will be a lot of time consuming as well as money consuming that we don't have. The low middle income countries, the lower income countries, they actually prefer to use alternative medicine, and they don't have money to spend on that classical research pathway. So how do you obviate or deviate from that research pathway, and you directly come on the humans for that alternative medicine research? How do you obviate that ethical concerns?
Thank you very much. I think this is quite a deep and complex question. So I agree with you. This is highly complex. So, for example, in the area of TCM, traditional Chinese medicines, often they're multi-component, and because you're talking about herbs, biological, materials, even the way you extract, you process, it will lead to different, chemical components, which may exert different side effects. So I can only speak experience, for example, in the TCM field. Some of the ones like I illustrated, berberine is relatively well studied. And then I think for that, we can probably say, okay, if this is a berberine containing herb, we can probably, infer that, there's certain interactions or certain efficacy we need to be thinking about. But I think if things like, for example, I don't know, cinnamon or other things which are very well studied, I would personally move just straight through an efficacy trial, like, I think, just, properly conducted. So we are even trying to do a placebo-controlled herb trial where we are actually comparing the real herb versus a placebo herb, and also trying to use some of the technology you mentioned, the CGM, or OGTTs to look at whether it's efficacious in preventing people with diabetes. So I think maybe sometimes because we find that in our setting that especially people with pre-diabetes, it's very hard to persuade them to start on the drug, even metformin. So we find it's actually probably easier to conduct research in this sort of pre-diabetic space where there's probably less potential for herb-drug interaction, and we can monitor the efficacy a little bit easier. But I think number one is that we need to have crosstalk with different practitioners. So we have formed a good relationship with the Chinese healthcare professionals. So even things like reporting adverse events, AEs, so they have a different concept. So, for example, berberine may cause your tongue to be a bit bitter, or have different GI side effects, which has a different connotation compared with Western medicine. So I think some of these things we are trying to learn. But yeah, I'll be happy to hear from other panelists as to what maybe people with diabetes think on how we should take this forward.
Well, as I said, that we need to understand, we need to make patient empowered, that we are not going to say that this is right or this is wrong, but they need to monitor their health, their glycemia, the levels, and also, for example, I myself is witness that many people are there out there who says the cinnamon is very good, and even there are some studies as well. But my own 4 patient has kidney issues after using that. You know why this happened? Because we don't know how much we need to use, when to use, how long we need to use. So this is we need the steps to empower them, that we should take the evidence, we should take the guidance of their healthcare professional, we should monitor our glycemia and our overall health, then that is okay.
I can make a comment on this. I did a degree in Reading University on supplements, particularly studied 2, chromium and zinc. And they were manufactured by a manufacturer, like a drug company. Now, obviously, the conflict here is the conflict between my tradition is to take this herb or this remedy that I believe in through ages, and my grandparents were taking it, versus the manufacturing of it and the potential interactions with other drugs. While I was working in the human nutrition department in the university, I came across many herbs that have very potent effects on blood pressure, on heart rate, and whatever. And perhaps the person who's taking this doesn't know that this can cause bradycardia. You're on a beta blocker, you can end up with a complete heart block. So it's the importance of the transparent discussion and for us to understand. Normally, what I say to my patients in clinic now, after doing this research, if you believe so strongly in it, take it, but monitor. If it's helping you, carry on. If it's not helping you, then don't waste your money. Rather than many people would stop their therapy and start taking a remedy, and then they end up with ketoacidosis. So I agree with Aram that the importance here of making sure that at the same time there is a discussion and empowerment. We know what they're taking. We try to understand what it is rather than simply dismiss it. Oh, you're taking this herbs. I wouldn't approve it. But understand what it is, what can it do, and monitor the effect, whether it's on weight, blood pressure, glycemia, whatever.
Well, if I may add here, in the first oral medicine for diabetes was from a plant. That's the metformin. That was originally from a plant. That's one thing, but most of them are not evidence-based. And we ourselves have screened large number of plants, and some we found have folkloric reputation, but instead of lowering blood glucose, it raises blood glucose. Like one plant we got from Nepal, Stephania hernandifolia. It raises blood glucose, although it's used by the diabetic. So the point that Hiram and Hassan said, I said in the beginning, that we have to emphasize to the people that if the plant is safe, you may try it. But please check that is it helping. I think that's very important message. Also, if you have done work on that, you will find different plants may act in different way. Some of them works better if you take it with food. That means perhaps they help by slowing absorption.
Yeah.
Like main action of Trigonophenum grigam is that it slows absorption. It has got a large amount of soluble dietary fiber, this Trigonophenum grigam. But some of them acts better if you take about 15-20 minutes before food, like she showed that picture of the bitter gourd, you see. Yeah, it's called bitter gourd, you see. And that acts better if you take it before food, because perhaps it stimulates insulin secretion, you see. So there are many things to study, and also one very complicated thing, there is still no real proper way of studying, like we do LD50. You cannot do LD50 with whole plant. Impossible. Because you see the animal will die because of choking. Then this LD50, these are all worked out on single compound. You see. But whole plant is difficult. Also, the plant is not uniform. You see. It depends on the growth of the season. It depends on where it is grown. It depends on which part of the plant. You see, it's very not very simple issue. It's very complicated issue. Also, I must say one thing, that about let's say 150 years back, the doctors were using substances which were really an art. It's a very famous quote by William Osler was, the success of a physician depends on whether he can keep the patient and his family amused long enough for the disease to run its natural course. You see. And at that time, William Osler was research professor of medicine at Oxford, you see, because we had nothing, you see. But subsequently, we found agents, initially what we called symptomatic medicine. But then we got fixated by pure chemicals, you see. Because some plant may be effective, you cannot find a simple pure chemical, you see. Because the whole plant is effective, not individual parts. So there are many complicated issues, you see. But I think the take-home message should be that you can try plant or natural substance, provided it is safe, but please check that whether it is keeping your diabetes under control. Otherwise, in present day modern medicine, virtually all diabetes can be controlled. Please.
I don't really have a question, it's just a comment. Whether it is using alternative medicine or the traditional methods or even fasting, sometimes patients will do what they want to do. And so the better way to tackle this is to invite them in, say, yes, you can do certain things under, so we need to have guidelines or, sort of some data, some evidence that they can do certain things. Like if they are willing to fast, regardless of whatever you say, so, they need to follow certain guidelines so that they're safer. And same goes for alternative medicine, whatever traditional herbal products that they're using, they need to at least know, what is at least the top of the cutoff point that, at least don't exceed, at least don't eat it with certain other ingredients, or, you need to learn the interactions. So, yeah, that is what I want to say.
personally, I kind of half agree. So I think, of course, we need to have a discussion with our people with diabetes about what they want to do, but we also need to understand and come with a scientific opinion. I wouldn't necessarily say yes for everything. I need to understand whether it is safe to say yes or whether it's unfair to say no. So it's a balance between based on the information, and obviously that will dictate on whether we can say give it a go and try, because I wouldn't say give it a go and try if I know that it's harmful. I also wouldn't say it if I don't know anything about this. And that's kind of like the main discussion on when we talk about fasting and pregnancy, is because we're not sure what happens to the baby. So can I, in that case, can I say yes or no? Well, if I don't know, then I obviously safer to say you're better to avoid it. So it's of course we need to empower people and listen to them and understand. I mean, the earlier session that we had just an hour or so about different types of fasting, non-religious fasting or whatever, it's essential that we understand what is the culture of this person, what's the religion of this person, what are the beliefs of this person, and then assess the safety of it from a diabetes point of view to be able to give an opinion. Otherwise, I would raise my hand and say, I don't have a clue, ask someone else.
Thank you.
Please.
Just very quick comment. So I echo, I mean, I think I'd rather they're using it in a complementary manner than alternative. So one example is that I do have a patient with type 1 diabetes who really do not want to give any insulin and instead decide to drink bitter gourd juice every day. I mean, I think this is highly dangerous and I would definitely advise against that.
Just to refine this point, on the basis of this, if I know, if I don't know, the cultural, the herbal, the traditional foods, each one, they decrease or increase glycemia, or it affects diabetes or not. Do we have enough scientific evidence-based studies on the basis of that we can say that these are the good or not good? If yes or no, can at this platform we recommend that why not we do research on it?
It's a very valid point. The problem is nobody owns this. So when I was personally doing my research on zinc and chromium, it's a natural supplement. There is no drug company or a company that will own it. So the funding and the ability to do comprehensive, robust research that takes large number of people is very expensive. And eventually it will be done when you cannot protect the products. Not like a molecule that we developed and that is patent for the next 10 years by us as Five. So that's the difficulties is in coming to this robust evidence-based medicine on supplements or herbal remedies is because there is no ownership to the component itself, and hence it's very difficult to come to that level of evidence. And the other point is people like it and they do it and they take it. So if you're the producer of that supplement, why would you do a study? They're already buying it in droves.
Maybe I think I'll also supplement that. I completely agree with you, and I think at certain point there are research going, and I think there are sometimes where the public funding has to consider that. And because if this is important enough, actually the government or the public funding agency will look into it because it is popular among that population. Then I think it's and I think as Elaine has mentioned, in Hong Kong there's an integrated clinic. We do have it in Singapore, and for example, I know Harvard, they have actually a very established CAIM, Complementary Alternative Integrative Medicine, that actually looks at things very scientifically. For example, we know that they do a lot of herbal, they do some acupuncture, they look at the metabolism and the microbiome as well. So I think some are coming as well. So I think it's good to look at that from that scientific aspect as well.
I want to share my experience. I'm working as a clinical dietitian, and right now we have done a research study on this topic, and you know, more than 60% patients are taking these kind of things just because of social media. people are too much towards it. By seeing the videos from by Facebook and YouTube, they're inclined towards it. So how to handle this kind of situation? They are doing many kind of things, and the main thing is they are misguide people, making false claims. Sometimes they leave their medicines. This is the main issue right now we are facing due to that major disadvantage of digital platform.
For a professional, a bit of practical advice, I would say, about the safety issue of plants. You see, I think it will be fair to say plants which are edible are generally safe. Although, if you see from your pedantic scientist point of view, that may not be so. Because when you see the edible, then we don't eat it every day, you see. So whether taking it every day is safe, you see, that's another issue. But anyway, as a whole, we can say if the plant is edible, that is, can be taken as safe. You see. Because safety is an important issue here. Because generally people believe plants are safe. But as I said in the beginning, Socrates was killed through a plant. And some plants can be very toxic, you see.
Sir, I would like to answer the question of Tamina, that how can we banish this social media promotion and everything? Well, we can't do this because this is a big system. But instead of that, we can introduce our channels. We can introduce because social media is not only for those who are spreading the wrong information. That is also for all of us. So we can do this, and this is very easy and in fact very cheap. So we can introduce that. We can go for the step-by-step approach. We can create the channels. We can use the Facebook. We can use the post. We can use the videos. So that's how we can empower people with diabetes, that what is right and what is wrong.
I think we had a very interesting session.
Can I ask one question from Dr. Wong?
Please.
Thank you so much. So, Dr. Wong, hello. It was a good presentation by all the speakers. I have 3 questions that I really want to know about. Number 1 is FMT commercially available? Number 2 is, out of probiotics and fermented foods, out of these 2, which one you think should the patients prefer, and what could be the possible reasons for these? And also, what are your thoughts on the concept of postbiotics? Thank you.
Thank you very much. So 3 questions at one go. So let me think about it. First question is on FMT, yes, okay. So FMT, I think it depends on the places. I think in US, for example, we know that the largest supply is Open Biome, which is non-commercial, but in a way they operate, so it's in a way a non-profit-making organization that they do. But I know that they supply quite a lot, mostly in the context of recurrent C. diff infection, but in a way they have supplied more than 30,000, so in a way. In Asia, it depends. In Singapore, for example, there's one commercial company that does that. In a way, they recruit donor and then they deliver as kind of, it's a commercial organization. So there are bits and pieces, and I think different places they do differently. In Hong Kong, for example, it's available in the public service. In Europe, I think a lot of either academic or hospital, they have some of those services as well. So it does varies, so it's hard to conclude. So this is one. Second is prebiotic, probiotic. I think when we mentioned about the probiotic, it has been there actually, and people have been using it for decades. And I think the softer bit is that we haven't got enough sufficient good, high quality evidence as a medical drug or indication. But I think the other bit is that, as we mentioned, the next generation probiotic is also coming. And these are bacteria that I think we did not know so well, but in a way, for example, Akkermansia is one that they are approved by Europe as a health supplement. So they are on the market, and in a way, you can buy it on Amazon, etc. as well. But I think continuing, we should be seeing a bit more evidence. One thing that we know actually for probiotic and microbiome, that the mechanism, the biology is actually there. The question is whether it is potent enough that if you take a capsule, that it will change the microbiome. And I think to me, it is a little bit like a drop in the ocean. So the biology is real, but whether the effect is potent enough and sufficient is another question. So this is something that I think we need more evidence for. Postbiotic, I think this is an excellent concept actually, because I think a lot of the probiotic acts through the metabolite that they produce. So, and we know that, for example, butyrate, short-chain fatty acid, they are biologically very important. So I think it does make sense. Large part comes down to what effect it has, the dosage, the formulation, and how to get it and deliver it to the place that we want. Okay. Thank you.
I think you will all agree that we had a very, very fruitful and interesting session. It remains for me to thank all the speakers who made such a useful and such an enjoyable presentation, which is very difficult in that short space of time. And I especially thank all the attendees because you have made this session lively and enjoyable. Thank you very much.
Thank you. Thank you.